Welcome to COVID-19 rounds. This is James Knudsen. I'm a family physician here in Thunder Bay and the Associate Dean of Continuing Education and Professional Development. We've got a wonderful presentation on COVID-19 and women's healthcare in the North. We have speakers in Sudbury, we've got a moderator in Thunder Bay, and we have all of you across Northern Ontario. Just a reminder, please mute your audio so that we don't get feedback. And you'll probably find if you mute your video that the images during these slide set will be better for you. As you join us, you will have an opportunity to ask questions through the presentation, and we'll touch on that in just a minute or so. As a number of you are aware of, the COVID-19 website, which is an opportunity for you to access information during and before and after the presentation. On the website, you will notice that this is your evaluation link. We hope that you'll complete an evaluation at the end of rounds, and that will provide you with a study credit application if that's important for you. And from the rounds page, you'll see today's presenters, presentation, and learning objectives. Presentation archives, which is a button at the top here. This is how you will access the archives. And as you can see already, is that our presentation slide set is available on our website, and you will be able to view that following the presentation as well. Clinical resources links you to the NOSM website, where we have clinical resources, and our presenters will be commenting on the COVID-19 case status in Northern Ontario. Presently today, we have 3 active cases in Thunder Bay, none in Sudbury, and you can see there are a total of 7 active cases in Northern Ontario. On this website, you will be able to find some materials relevant to today's presentation in terms of our maternity care resource site as well. So feel free to browse on the website following our presentations today. Our rounds committee does not have any declarations to declare. And as you are aware, our knowledge of COVID-19 is rapidly changing, and that our information that our presenters will share with you today are consistent with the literature that we're aware of today. Please remember that the literature is changing almost on a weekly basis, and that new information is continuing to come out. For questions during our presentation today, please push your questions to Sarah Bazinet, who's our host, and she will be tabulating those questions so that we can then forward them to our moderator for today. And so I'd like to introduce our moderator, who is Dr. Amber Dudar. Amber is an obstetrician gynecologist practicing in Thunder Bay. She's been practicing for the last 11 years and has a full scope of obstetrics and gynecology. Amber is an assistant professor at the Northern Ontario School of Medicine. She's involved in teaching both medical students and family medicine residents, and she's also on the planning committee for the Northern Ontario Women's Health Conference. Over to you, Amber, to introduce our presentation and our presenters. Thanks so much.
Welcome, everyone. So we have 2 presenters today. Our first presenter is Dr. Karen Splinter. She is an obstetrician gynecologist, and she joined Health Science North in Sudbury in 2012. She did her medical school in Ottawa, and then her residency in obstetrics and gynecology at Memorial University. She is an assistant professor at the Northern Ontario School of Medicine as well, and is passionate about improving healthcare for women in the North. Our other speaker is Dr. Jennifer Jocko. She is an obstetrician gynecologist as well and works in Sudbury at Health Science North. Jen started her journey in medicine as an RN and worked as a nurse for over 10 years in Mattawa and North Bay. Then she went on to medical school at McMaster and did residency in Ottawa with a shared residency in Thunder Bay with NOSM, which is where she became my colleague and friend. Now that she has started her career in Sudbury, it is no surprise that she is very busy. She has a regional focus where she does outreach work to Manitoulin Island, Little Current. She works with an Aboriginal midwife and improves access for Aboriginal health. And I'm very excited to hear both of them speak today. To you, girls.
Thanks, Amber.
Thank you.
Thank you, James. Good to see you.
Share screen.
Yeah, so share content. Thanks for the kind words.
Yeah. Okay,
And did you change it?
No.
Okay.
oh, darn.
There we go.
Okay, everything's okay?
Can you see our talk okay?
Yes, we can.
Okay.
Yep.
Okay, I'll be in charge of the tabbing.
Perfect. So, everyone, thank you for taking some time out of your lunch break to come to the weekly COVID rounds. We were quite happy to kind of provide an overview of OB-GYN care in the North and the impact of COVID-19 and how it's impacted our practice here. But can't really talk about COVID-19 without talking a little bit about some of the statistics. I won't get into them too much. I wanted to specifically focus a little bit on Northern Ontario, although the slides which were updated as of June 3rd even changed as of that day in terms, and I'll show you where that happens. So we hope to discuss some of the status of COVID-19, specifically Northern Ontario and First Nations, as well as describing the effect of COVID-19 and what it has on maternal and perinatal health story, as well as cervical cancer screening. I'll summarize with management here of women with or COVID-positive, both what we're doing at the hospital and then how we're managing things in our own practice with the social distancing approach. So coronavirus, it is obviously everywhere in terms of we've had a lot of, we were learning so much more about this even compared to, 2 months ago. Oh, too fast, don't touch. Anyway, so coronavirus is a large family of viruses that originally found in Wuhan in China. And this is this most recent strain. We know that this coronavirus leads to and can cause even just minor respiratory symptoms, but it can also lead to very severe lower respiratory tract illness and certainly detrimentally affects lives and it causes mortality. So as of June 3rd in Ontario, COVID-19 cases in Ontario were 29,047 with 2,363 deaths. This number obviously for unfortunate reasons continues to go up a little bit every day. In terms of the deaths in Ontario, this was as of June 1st. This is the tracker off CBC News, which has some pretty good data tables and charts. As of June 1st, there were 2,336 deaths. You can see where we're at in compared to the rest of Canada. Specifically Northern Ontario, these are the active cases in the public health units in the north. This was June 3rd, so as of noon, which would have actually, we would have added 2 more for Thunder Bay. So there would have been 5 active cases. There are 2 other active cases in North Bay. We still do not have any active cases here in Sudbury. So this is a nice little snapshot that includes also some of the First Nations that report into those health units as well. In terms of COVID-19 and First Nations, it's hard not to really, the COVID-19, not only in Canada, but also in the United States and other countries, really highlights the disparities of social determinants of health. And I think this abbreviated conversation is not really it could be a whole afternoon of talking about those types of things. The federal government certainly has helped a little bit more in this pandemic compared to H1N1, and there was a lot to be learned from that. So certainly more federal funding has been filtered down to the First Nations, and the uniqueness of some of the, often those, a lot of those communities are able to close and block access, hopefully then decreasing the amount of transmission of COVID-19, which has helped them. Although one can't really talk about those social determinants of health and those social disparities without talking about, because the main push for health prevention in COVID-19 is hand washing. And I was actually in a conversation with my kids about this. There are currently 60 boil water advisories in Ontario alone. And you can see a lot of them are in the north. The red flagged ones are actually do not even use it for showering. So there are 4 of those. One of those actually includes my home reserve, Pikwakanagan, outside of Pembroke. But there are some even within throwing rock different distance between an urban center. So certainly, hopefully, going forward, this will highlight not only the disparities, but perhaps even more important, the need to provide or help with federal funding for providing clean water so people can wash their hands and be safer. And that's only just a snippet of it. So pregnancy and coronavirus, there's a really nice systematic review of 108 cases. This was updated as of just before early May, I want to say. The one that was not included was the recent article in the CMAJ of the neonatal transmission or congenital transmission, that is. What you can see is that of the 108 cases, of those in that time frame, 50 of them were delivered, and 44 of them out of that group were delivered by cesarean section. Looking at the case reports individually, or even the case series, it's hard to say. Most of the time it was maternal concerns for the cesarean section. In this cohort, there was no maternal deaths. The neonatal mortality was, and as well as the incident fetal death, was a woman who had significant multi-organ dysfunction, basically had a C-section in her ICU room, and the baby was stillbirth. So certainly women are not pregnant women are not without risk. We do know that viral types of pneumonia, even if we look back to SARS, certainly can cause significant morbidity for a pregnant woman, especially in the 3rd trimester. With looking back at that data, about 25% of women often need some sort of hospitalization or ICU admission. So certainly COVID-19 we treat very seriously, and it certainly has helped, the evidence has helped guide as we go day by day, week by week, in terms of hospital management of pregnant women, as well as our community practices. There is a similar born system. The UK has an obstetrical surveillance system that they've been using to follow pregnant women. And what they found in the UK, that 1 in 10 of those women that were admitted with COVID-19 did require ICU. And they had 5 deaths of women with coronavirus, although again, looking through the data, it wasn't quite clear exactly what caused the death. And then again, the majority of women who become seriously ill tend to be greater than 28 weeks. We know certainly that how it's transmitted, droplet transmission, aerolized procedures. There have been suspected cases of perinatal transmission. The numbers are low, and they really feel that, and looking at a lot of those case reports, are because of the variation of testing that's done. The timing of it, is it 36 hours after a delivery? What is the state of breastfeeding at the time? Was the babe isolated or not. And then the case report that was in the CMAJ released just a couple of weeks ago seemed to feel that there were certainly a lot of, oh, I spelled that wrong, features of that could support congenital transmission. I think the key thing to take away from all of that is that at 30 days out, these suspected cases, as well as the other case report, show that at 30 days, these babies go home without any long-term sequela, at least not that they could see in the immediate time. So baby home 30 days, outcomes were good.
Water.
Coffee.
So guidance for pregnant workers, maybe bless their heart, but the SOGC didn't have much to say. It doesn't tend to be a very aggressive group from a guideline point of view anyways. I think we were anticipating the Americans would have significantly more aggressive guidelines coming out that they didn't. So we're still sort of using ours to focus on the British or the Royal College in the UK. They really, before the outbreak really hit in North America, within the first week or two, I think, had published this guideline suggesting that healthcare workers after 28 weeks should be put in sort of non-clinical situations where they were going to have direct access. So anybody within 2 meters of a patient who was pregnant 28 weeks and beyond, they had advised against that, which at the time seemed quite above and beyond aggressive compared to what we were suggesting in North America. I think many of us assumed that the Canadian and American societies would follow suit, but they actually haven't. But because it's the only really public paper that might be relevant, when we in our practice certainly reference it a lot when patients are, particularly healthcare workers, are sort of saying that these are the exposures that I might have. So somebody in the emergency department would be huge. A little bit the operating room for sure in our patients, ICU. But even like I can think of a healthcare worker who works in the cancer clinic, right? So nobody that you would know coming in for a treatment has COVID, but it doesn't mean that they don't. And for a while there, they didn't have enough barriers and PPE to protect them adequately should they be exposed. So we've certainly been quite happy to write a lot of letters to modify duties to get them out of those sort of high risk situations. Management. So these next few slides have a lot to do with what both the Canadian guidelines as well as what we did here in Sudbury. Our big things was we very, very quickly revised the office schedule. We have some of those slides in a little bit later, but really just to say, instead of having a waiting room that might at any given time have 4 or 5 or 10 people in it, especially with the support person, the +1, the other children, suddenly there's like 0 people in our waiting room or 1 person briefly waiting. Which has helped tremendously with the potential for community spread that we didn't have, thankfully, in Sudbury. Antenatal surveillance. So again, every hospital and birthing center is quite different. Sudbury does their non-stress tests up in the birthing center. So you're walking through the hospital-based screening. You're then coming up, getting screened again before you come into the locked doors of the birthing center. You'd be seen by at least 1, if not 2 nurses during your encounter after you stopped at registration to register to come up. So you interacted with at least 2 hospital employees, if not 3 or 4 by the time you had your non-stress test. We said, yeah, it looks good, and off you go. So we very quickly, mostly actually with the guidance, some guidance from Dr. Jocko, said, okay, how do we get these people not here, right? Because you just don't know who might be infected, who's on your unit. So how do you prevent women from coming in for a test that's supposed to be helpful, I guess, and preventative without accidentally getting her infected? So most of our non-stress tests were canceled. We started most of them, just the higher risk ones, at 36 weeks and onwards until delivery. So our volume of non-stress tests down, I'd say, is probably 70 to 80% down. But we're still focusing a lot on biophysical profiles, so ultrasounds that were done in a different part of the hospital that was already easier to distance from each other as well as other healthcare workers. We're just sort of using that data differently. And thus far, I think we've been quite lucky. We haven't had anybody that we regretted, right, what we did. So that's been quite helpful for our unit, certainly to get volumes down. Office-based visits, again, everybody's unique, but for the average woman, we were able to cut down about half of her visits to virtual visits, but that also allows us to call the patient, talk to her, screen her for any worrisome symptoms, go over movement, cramping, bleeding, all the usual we find a time for them to safely come in by themselves for an assessment. We spent a lot of time at the beginning, and certainly even now, reassuring people that the hospital is A, empty, and B, quite safe and clean. We don't want people not to come to the hospital when they need to come. But we always had a good unit where the nurses were quite happy to talk to patients on the phone if they called in with questions, and now they're just above and beyond, almost better about that, that when a patient calls and describes her symptoms, if they're worried, she comes in for assessment. If it seems like something that can be managed at home, then she stays at home. Moving on. All right, yeah. Yes. So I don't know what other hospitals, ours is literally called the pandemic plan. We're on version 9. It's 112 pages long, I think, but it's probably like 40 pages, but it's quite lengthy. But for us, it also includes the pediatric program because we're a combined unit. The big highlights of what the pandemic plan changed for us overnight was no visitors at all. So no grandparents, no best friend. You were allowed one support person for labor, delivery, and postpartum, and that was it. Also means that your 2-year-old child who used to be able to come in at specific times and visit your mom and new baby is no longer welcome. We really haven't gotten much negative feedback from that, though, so hopefully everybody else can say the same about their units. We've had the occasional person who was upset that an extra person who in normal times would have been allowed to come. One of them was a gestational carrier, so the parents weren't allowed to be necessarily at the birth if the mother delivering, for instance, had chosen someone else to be her support person, but that's a pretty unique situation. Most other patients are admitting that it's actually not that bad, you know. They have their baby, they're there with their support person, they spend 24 hours and then they're out the door, and it's probably a little more relaxing. So it'll be interesting to see the trickle-down effect, how long we blinked. So screening and testing, everybody gets screened upon arrival in our hospital before they hopefully come into the building by the screeners or as they're coming in. For us, if you were screen positive and you're swabbed and you're swab pending, you have droplet precautions in labor. You have enhanced airborne for delivery. That was a bit of a hot topic in March for us. As the obstetricians in the room, we were very happy to take the enhanced precautions within 95 during pushing and vaginal birth. Originally, because of droplet precautions, it wasn't considered necessary, but because of the concern about having to ventilate the baby and particularly the mother, we did as a group agree that that was reasonable. So we're doing enhanced airborne for delivery, be it vaginal birth or C-section, and continuous fetal monitoring and labor. As Jennifer pointed out many slides ago, the C-section rate for that one case cohort was 88%. So our hospital baseline rate is 25%. So obviously astronomically higher. Some of that was probably from fetal monitoring. I'm sure a lot of it had to do with concern about the mother. All of our elective surgical patients at Health Sciences North are getting a preoperative COVID swab, so our C-section patients are getting that too, even though the likelihood of general anesthetic is quite low. And the turnaround time for us, depending on the time of day, is hours to 12 hours usually max. So we've been quite lucky about that. We also now have an enhanced questionnaire that was developed because of anesthesia concerns, and it came about with a case that at 3 in the morning they were doing an emergency C-section that they almost had to convert to a general anesthetic, and as the anesthetist was staring down the throat of that woman thinking about intubating her, she was like, son of a gun, right? What do I even know about this woman? So they now, all of our laboring patients upon admission to the unit get an sort of enhanced questionnaire that has a lot to do with social risk factors. So do you live with a healthcare worker? How many times were you out grocery shopping? You know, they try and ask more delicately, have you been abiding by the social distancing rules, yes or no? And then the anesthetist will question them if they think that there's a chance that this person could be an asymptomatic carrier. They're actually allowed to order a COVID swab, but we don't necessarily put them on isolation. It sort of allows us to maybe potentially, I guess, find that person who was an asymptomatic carrier before too many other people got infected. So far, we haven't been ordering many, but the ones that we have all come back negative. But we have an LDRP model, so that's labor, delivery, recovery, and postpartum for somebody who is COVID suspect or COVID positive. So that just means that she stays in our one isolation room the entire time she's there, which reduces transfer in the hospital, which hopefully is reducing the chance of spread while you're transferring her. The only exception would be if she has to go to the main operating room for delivery, our operating room for a C-section, or has to go to ICU. She would be on droplet precautions in labor and postpartum. Again, a little bit of debate, certainly with pediatrics as well, that the baby was probably swabbed right around the time of birth and then within 24 to 48 hours. Again, as Jennifer mentioned with the other case study, it's still a bit debatable to say the vertical transmission versus contamination after birth. We had some contentious meetings at the beginning about policy is that mothers should be allowed to breastfeed if they choose to. Just remind them about very careful hand washing, so hand hygiene, wearing a mask while they're breastfeeding, separate them when they're not breastfeeding from at least 2 meters or a curtain or both. Lucky for us, that hasn't really been an issue because we haven't had any COVID. And we didn't get any resistance from the hospital, but obviously if the mother's unwell, she's going to the ICU for management. If she's still pregnant, we will arrange assessment for the baby. And if mom's postpartum, then she goes to ICU and she stays there and the baby would have to go to pediatrics. Still me. Oh, I almost drank my soap.
Here, I can take a little bit. You drink. So what do we do here? It certainly has changed, as we alluded to a little bit earlier. We typically, on an average day, could see between 50 or 60 patients. And we've now gone to about 20 spaced out nicely every 20 minutes, 15 to 20 minutes, so that we don't have people waiting. Typically they come in, and in terms of the pre-screening on the phone as well, we remind patients that we don't want them coming with anyone. Their partner can come, but they unfortunately have to stay in the car. We recommend that if they don't have their own mask to wear here, that we have one provided for them. And their hand sanitizer meets them at the door. And it's really, we're trying to reiterate to them that we are not only protecting them themselves, but also protecting our staff. So we pre-screen everyone on the phone, and there's a passive screening when they arrive. It certainly makes for much, obviously a much quieter office. But also we get a lot of good feedback from the patients, makes them feel a little bit safer, knowing that they're the only ones here basically, and rarely do they have to sit in the waiting room even once they arrive. Certainly there are some challenges with partners, because we can certainly empathize with the fact that they aren't hearing the heartbeat. So we offer that, they're welcome to call partner at time. They can record the heartbeat. And certainly when we do an OTN consult, they can both be on the video or on the phone. We basically do the passive screening at the door. We also review this on the phone with them before they arrive. We really try to get the message across that if you're not well, we don't want to see you. And there are no concerns with booking fees or last minute cancellation fees. By all means, we're happy just to have a phone conversation with you to check on the patient. This is a picture of the front of our office. And we recently just had this plexiglass installed a week ago, after waiting for almost a month. I think it was, the plexiglass was delayed and the hardware was delayed, but it offers a really nice barrier and protection for our staff. It looks really nice, eh? It's a great picture. So when patients come in, so the vantage point from where this picture was taken is the front door. Certainly our staff feel much safer. Patients can sign forms, slide them back under the desk or under the little pass through. But it's it's a change to the office, but it still keeps a nice flow. Mm-hmm. So securing PPE has been a challenge, as most community practices, I think, have also faced for sure. We uniquely as well have a fertility clinic, and we do on-site lab and ultrasound. We've slowly just started opening that back up again, and part of the delay also was until the change in the amendment to Directive 2, but also PPE. So doing blood work, you need to have a face shield, and we had to procure these on ourselves, and there was a delay, and these are only really borrowed, along with gowns that we were able to thankfully borrow from one of the plastic surgery clinics. And while ours from Amazon come in, which won't be here until August, most likely, because we're needing other PPE when we do sonohistograms or when we're doing insemination. That's been part of our slow startup, which has been a thankful process. And to just be mindful of the additional staff also that are in the office as well, again, to keep everyone safe. We really promote mask wearing when we can to all of our patients. This is probably the closest we've ever been in months.
It actually is.
It is. It is. We've certainly have seen some feedback, perhaps even on social media, about mask wearing, but we promote it quite readily, and we try to be quite diplomatic with the patients in terms of basic bottom line is keep yourself safe, keep our staff safe. And the masks that we provide here, I don't know if you have, but a couple of patients I know that don't have a mask, and they get to keep their mask as long as they bring it back when they're coming back for their visits, especially if they're not able to access a mask on their own and they are potentially the primary person going out to get groceries and things. I want them to also be safe. So I've provided them with their masks that they keep, that they can have. So we were able to procure about 50 cloth masks. So we wash them every day. We also wear scrubs when we're in the office, so those get washed every day. And again, just trying to a safe work environment.
We're also lucky we have laundry on site, so we can encourage our employees to actually leave their clothes that were within patient contact, I guess, here, so they can sort of undress here in the office, leave their potentially dirty clothes to use in our machine, so they don't have to worry about getting virus on their clothes and bringing it home to their family. Everybody always changed their shoes anyways, so it's been helpful.
We've had an enhanced cleaning, deep clean every day. We also clean in between patients. We disinfect the blood pressure cuff. We are typically, what used to happen was our front staff would check in a patient, do their blood pressure, and wait if we didn't have a nurse that day, and then we bring the patient down the hallway. So now we're actually doing all of that, doing a weight and blood pressure on the patient. We bring them into the room. So we're managing the patient flow, which again, when you're seeing a patient every 15 to 20 minutes, is manageable. And again, just decreases the amount of direct patient contact that our office administrative staff don't need to have with the patients. So
the WHO guidelines for prenatal care were always a lot looser maybe than what we were used to in Canada. You can see 12, 20, 26, 30, 36, 38, and 40 week to 41 week visits. Again, for our lowest pregnancies in Sudbury, what we decided to do at our office in particular was try and do OTN visits until 20 weeks. So that might be in a first visit between 8 and 9 weeks, depending on the patient, and then a follow-up around 12 to 13 weeks with her first trimester screening if she did it. And then a sort of late or mid second trimester around, say, 17 weeks, where we can make sure that we've ordered the anatomy ultrasound. And then so by 20 weeks, they're seeing us in the office for the first time. And obviously, we're assuming that this isn't a woman with, for instance, undiagnosed hypertension. The only other major thing that we're missing from a health screening point of view is the weight, right? So we talked to them about a weight, but I know certainly some of our patients are like, well, I don't even know my weight. So for first trimester screening, I need their weight. So it's like, well, find a scale, please, right? Put it on your form. I need you to, right? But they don't hear the heartbeat is the big thing that they're missing. So some of them have tried to get their own Dopplers to do at home. And as Jennifer alluded, then obviously the partners miss being able to come into the visits and ask questions. We have had a lot of visits certainly over the phone with them where the patient's face-to-face with us and just puts her partner on speaker and he's 20 feet away in the parking lot. So what we did is sort of merge the WHO with our traditional one and just make 50% of them virtual. So we're doing a virtual visit till 20 weeks, then we see them in person at 20, 28, 32, 36, 38, and 40, and they alternate the traditional visits with a virtual visit either over OTN or just a telephone call. Another big thing that no patient was upset about was the Canadian Diabetes Association said you don't have to drink that delicious 50 to 75 gram glucose challenge. And it said they're just getting a random glucose with a hemoglobin A1C. Again, the patients never liked drinking that for the most part, so they're happy that they don't have to. But for our big thing, it's an easy sell. They said you basically make an appointment at, in our case, Life Labs. They make an appointment. They're hopefully in and out the door within 10 minutes. They just go in, register, get their blood drawn, and they leave. So I have seen very little change into the percentage of people that I'm referring to our diabetes clinic. And again, the diabetes clinic made a huge change. Usually patients were waiting for 1 to 2 hours sometimes at that clinic to see between the registered nurse and the dietitian and the internal medicine specialist. And now most of that's virtual. So one silver lining, I suppose, is some of our patient care has certainly improved, I guess, from a satisfaction and efficiency point of view. This is the Ministry of Health, and say we can send the actual documents if people would like. It was just we copied and pasted, talking about essential visits. We use this a lot to help us guide as we're slowly ramping back up. We've had very few people from a gynecology point of view give us a hard time when they called and we're like, no, you can't come in for an appointment for that. That helps us a lot, but we're usually able to call them back fairly quickly, so I think that helps our staff as well. We had a few people after Doug Ford announced that all elective surgery was resuming call us hoping to have their surgery done in a few days. And I was like, I know he said that, but he at the time hadn't lifted directive number 2. And our hospital is doing a very slow, careful ramp up. So even when we're now doing surgery, we're doing it much less. We have to be much more careful with the patient selection, a healthy patient that can hopefully come in and out of the hospital quickly. But also we're working at, you know, between 70% maybe capacity of a usual surgical list. So fewer patients, operating at about 50% of our usual volume starting this weekend. Ask me about, do you have a surgery? And you can sort of say not soon, right? And I have no idea. I'm sorry. But.
And part of that as well, in terms of the teaching that happens with the patients about operating, is especially using Thunder Bay as an example, where they started their phase 1 ramp up and then unfortunately then had an outbreak of COVID. So then they're right back down to closed again. So we try not to book too far ahead so that people are, again, getting their hopes up and getting canceled. And this is the first week of it. So hopefully we'll continue to progress. We'll hopefully be back up to maybe 100% by September, they say, maybe, or starting in September, because now summer, a lot of nurses and staff will be taking holidays over the summer after a very stressful spring. So we'll only be up to 70 to 75% through the summer.
Again, that's Health Sciences North. That was their decision, that they said, we're not going to cancel our previous always scheduled summer slowdown. We're going to maintain that. It gives us some flexibility. We have had a few like positive, poor choice of words, but where the operating room will say, actually, I do have enough staff to do another room, who needs it? And they'll be like, hey, gynecology, do you want to book a case, a list on Friday? And most of the time they're like, yes, I'll be right there, right? So if things are going well, but yeah, normally I could tell people when I book their surgery, on average, expect that you're going to get called in 5 months for this, or 8 months for this, or 2 months for this. And now I just said, no idea, but you know, we'll call you when we can. I'm sorry. Can I answer the question? Do this.
We can answer
okay.
After.
Great. This document, again, we can share. This is Ministry of Health Ontario, but the interim schedule for children and pregnant women. So I only took a snapshot of the pregnant women ones, but it was just to remind us about the document. And again, they're talking about in office visit at 11 to 13 weeks, but we did not do that. We are instead emailing patients the forms with their permission. The few that don't have access to a printer can come pick them up.
We have an outside mailbox. We put their name on it, and so then they're not having to come in.
Mm-hmm. Office gynecology. So yeah, we up until this week pretty much only the urgents, and even then like suspicion of endometrial cancer. So I know Jennifer, I think, saw a few. I certainly did. Woman presents with postmenopausal bleeding to her family physician. I get the referral, we read it. We did triage most of them still with an ultrasound to help. If she had an atrophic lining, then we might postpone her. But in the meantime, we booked an OTN consultation. We can email them a questionnaire sort of through our EMR that they can fill out for their history, which helps us be very efficient with a consult, which helps. And then if we say you have too many things that make me think you need a biopsy, we found them a very isolated time to come in, get their biopsy, and unfortunately, obviously, some of them were positive, and then follow up from there. But the one I can think of spent less than 10 minutes, if not less, closer to 5 minutes within 2 meters of me, right? She didn't have to go within 2 meters of anybody else in my office either. So very efficient way. And, you know, I mean, it needed to be done. And she had no regrets. We've done a few high-risk IUD insertions. So for me, at least, that was women who admitted that they're very poor at contracepting. So we found a time for them to come in to get their IUD inserted because we have lots of business coming in November, December, and January already. So, but many of our booked IUD insertions that got postponed when we called them, we're quite happy to use something else in the meantime. There's also better guidelines suggesting that your Mirena IUD, for instance, is quite effective for much past 5 years, which like in our hearts, we always believe that, but now it's sort of more concrete to say, I think you're fine, you can wait a little bit longer before we change that. We're slowly and steadily starting a little bit more gynae, so a few more IUD insertions, some pre-op examinations, some pessary maintenance. But our big thing is that we're managing to do the overwhelming majority of our gynecology follow-ups virtually through either OTN or just a straight telemedicine. And the CPSO is actually also encouraging us to do that.
So in terms of cervical cancer screening and colposcopy, that they're trying to figure out prioritizing cervical cancer, well, just cancer screening in general. Currently, it's still on hold. In terms of colposcopy, most of, and in discussing this with the regional colposcopists, colposcopy is still occurring for high-grade AGC, AAS, and LEAPS. So that's reassuring. We were time here where we weren't when the initial shutdown first happened in early March. There was probably about 2 to 3 weeks where we didn't have any colposcopy. So all of our LEAPS were canceled. So basically what we're seeing now are our LEAPS and our HSILs and those kind of higher risk follow-ups. There is a revised guidance document coming down through the pipe again for pandemic management of not just colposcopy, but also in the realm of cervical cancer screening that should help primary care. There was some discussion about pushing a lot of these LSILs or ASCUS back to primary care to just repeat a PAP in a year, but I think that that's not fair to primary care. So hopefully we'll be able to have a document with a template that will have a clear direction of when do we want to see these types of cervical dysplasia cases. HPV certainly plays a big role in this, but unfortunately, I mean, that would be the perfect dive in for HPV testing in primary care to start, but that funding is not there yet, despite the announcement 2 years ago. So it's currently we're only offering HPV testing in colposcopy, so we're at least able to discharge some people that we do see in colposcopy back to primary care. But as I said, this guidance document will be coming down and out hopefully, hopefully the next, I'm hoping in a couple of weeks. They wanted June 1st was the deadline for modifications or edits. So hopefully it will be readily available and shared soon. So overall, what have we learned? We learned that telemedicine is the way to go. We certainly seem to be more efficient as time goes on. It's really helped us to streamline how long it takes us to see a consult on the phone and then or over OTN, and then their in-person visit becomes that much shorter. And they're getting in their height, their weight, their blood pressure taken, they're in a room, they get an exam, they get a biopsy or IUD in or whatnot, and then they're in here, as Karen had alluded to, maybe 5 to 7 minutes and don't encounter anyone else here. So that certainly has been a big change for us, considering we would see 50 to 60 patients some days. So overall, I think it's made us a bit more efficient, knowing now that we can do a lot of our follow-ups virtually, and patients actually appreciate that. Hey man, I could just talk to you on the phone. I don't have to drive in from work. I don't have to drive in from my 45-minute drive. I certainly did a lot more OTN because of my island patients, or telemedicine, and whatever we can do to make things more efficient, especially for our patients traveling in. If anything we've learned, especially from the pandemic plan side of thing in HSN, is there's so much communication that's involved, and so we really try to keep everyone abreast of things, whether that's ourselves in our group, our office staff, the nurses, as well as our patients. Kind of takes us to the question about how are we engaging patients and sharing their fears. Jill Riva is asking about coming in for visits, especially if not all the staff are wearing masks. What happens when they go to the grocery store? What are the recommendations? And certainly, I would say a majority of our first conversations, especially in March and April, were always about. I would say I spent probably 5 to 10 minutes talking about the importance of social distancing, and kind of reiterating what was coming down from Health Canada and the minister, and the fact that it's masks and hand washing, keep your hands off your face, that we're doing the same thing, and hopefully knowing that we are a mask only type of office and that it'll be provided for them when they get here makes them feel safer, and it's I think that's helped patients feel much more safe, and much more open to wearing masks, especially here in the office. We haven't really experienced too many people that refuse to wear it. We certainly would be, if we did experience that, would get some feedback as to their concerns about wearing the mask and address it from there. But that's hopefully that helps answer your question. I don't want to add anything more about.
Well, and so some of it with the mask helped, you're covering your face while you're within 2 meters of people. So it helps remind why that's actually a universal recommendation. It's not just in the medical office, but it's tended to be such an efficient visit now because of how carefully we're scheduling everybody, that they don't have to wear it for that long. So yes, if it's a bit hot and annoying or uncomfortable, but it's like you're hopefully in and out for 10 minutes. Maybe 12 kind of thing, right? But most of the time it's like, it's not that you waited for 30 or 40 or 50 minutes in my office. You didn't wait in the waiting room. So you were here for, it's a short little painful thing every 2 to 4 weeks, right? We were all wearing one, which helps too, that sort of, and it's a little bit not the herd immunity, but say that we're all in this together kind of concept, that you wore a mask, but that meant that the 10 people maybe I saw in the office today before you also wore a mask. So I remind them, I said, when you're speaking, there's droplets coming out of your mouth. So I said, we just have like Lysol and bleach everywhere. But I said, we could have missed something. But if you were covering your face, I'm less likely to have missed something. Right? So then you can't get sick coming to my office, and most of them can buy into that too. So it's not just you're doing this to help you a little bit, but you're doing it to help all the other people around you. And heaven forbid, we spread it to a whole bunch of people. So we've been pretty lucky. That answers your question, Joe. Yeah.
So this is it's actually Dr. Morris and I doing one of our first protected cesarean sections. I frankly was terrified, but
and hot,
and very hot. But yeah, this is the hashtag. We're all in this together. Yes, sir. Happy to answer any questions. I think
that's our last slide.
That's our last slide. Yeah.
Okay, thanks, girls. I have 10,000 questions, but I won't. I'll clarify a couple of things just for my own interest. So the N95s you guys are wearing are just if someone's screen positive or known to be positive?
Or suspected.
Yeah, and so that's for delivery, like vaginal delivery and dissection.
Yeah, we had an interesting debate about how much aerosolization you could potentially do with Valsalva in the second stage. There's a lot of spitting.
We had the same, because you guys know the guidelines don't say you have to do it, but we were on board for the same thing. But luckily, like you guys, we haven't had that many screen positive or people that have been suspected. So in general, we're not using that many N95s, but
yeah, we very few, right? So that helped too, I think. And then say in our case, the pediatric part too, that they didn't even want to be in the room in case they had to bank and mask the newborn. And the newborn's probably fine because vertical transmission is quite low. And I said, what about me and the nurse beside me, more importantly, right, who's maybe having this woman breathe on her for the last 2 hours heavily, right?
Yeah, no, I agree. A couple other things we're doing antenatally. It was interesting that you guys are doing less NSTs. I think we're maybe doing the same number of NSTs, but not in our office. So those high-risk patients are only seen on labor and delivery by the on-call obstetrician, and that is their antenatal visit as well. So instead of being at 2 places, labor and delivery for their NST and the clinic, because we don't have the ability to do NST in the clinic, that's how we've tried to make our offices less busy, where our high-risk patients are just seen on labor and delivery and spaced throughout the, like into the evening, spaced throughout the day, so it's not too busy on labor and delivery. Another question from the audience, and a question that we're facing is how you're involving learners in this pandemic where there is limited PPE, their potential exposure, that they still need to learn something. So we don't have medical students yet, but we do have residents that are still rotating through.
So currently we have, we didn't have any medical students initially. We had residents in the month of April and May. When we only kept them on labor and delivery, there wasn't an office component to their rotation at the time, given the PPE restrictions that we had or were limited to in the office. And we will have medical students, we hear, coming in July. Yeah, and we recently actually, we have a nursing student that's in the office that just started. And part of that was she would, her program provides her with her own PPE, which helps. But certainly as we get more learners, we will certainly have to be opening, the office for the gyne portion of their learning as well. In terms of hospital, I think that maybe you can speak to that, the hospital learners.
So yeah, around March 12th, maybe, our hospital got into crisis mode about PPE, and amongst other things, the barrier gowns that we wear at vaginal birth were on critical supply. We canceled all elective surgeries. We postponed as many emergency surgeries as we could. We canceled all inductions. We canceled booked C-sections for 5 days. But within that was also like, how can labor and delivery save some gowns? I said, well, I guess the learners, right? So all the medical students that were on service still for that week or two before they got pulled off, suddenly were welcome to be at the vaginal birth with, a mask on and gloves, but no gown. So unfortunately, our hospital went to paper-only gowns about 2 to 3 years ago. Whereas if we still had our Gore-Tex gowns, and they did that to save money, but if we still had those, we could probably have been wearing them for our low-risk vaginal births quite happily, right? But we didn't have them anymore. So it's taken months for us to slowly remind them that, like, again, we haven't had many family practice residents on, so they're the only learners we've had in the birthing center for the last 2 months. But they really should have a gown to protect themselves against all the normal stuff at vaginal birth. So they haven't had too much difficulty. And it's also just, I suppose, like, we don't have a +1 scrub in at C-section, whereas 4 months ago, maybe we would, right? We say, how many people do I need to do the C-section? They're wearing a gown, the other people aren't scrubbing, but
yeah, so we're similar here. We're wearing a different gown at labor and delivery, which I don't like it, but it's some alternative that they got. It's like almost like a plastic bag that's over your arms too, like a plastic outfit. So we have had learners. We had quite a few family practice residents rotate through, and we still had them involved because they're there to learn, but they were wearing these alternative gowns. But for C-section, I don't know what you guys are doing, but we've stopped having spouses in the C-section to try and save on PPE, which with the husband partner waiting in recovery, which has been you know, a bit of a learning curve and issues for the families, but they're trying to do the best, you know, we can with sometimes a phone on in the operating room to FaceTime or take pictures or whatever. What are you guys doing for C-section support person?
We're still letting them in. The highlight differences is like our disposable hairnets have changed, like the caps. Again, a few years ago we had reusable ones, but those all disappeared with the laundry changes. They're not wearing a surgical mask. The support person is wearing a different sort of face mask from the hospital. And I feel like not wearing booties, but he's still getting scrubs, or he or she, right? So we're letting them in. Again, we've been lucky that you know, I mean, we still feel quite strongly that it's nice to have that support person at the birth. So
for sure. The people in the chat are also asking to clarify support people in labor. So in Thunder Bay, they're allowed one support person who cannot leave the room to go get food or to walk around the hospital. So they're supposed to pack their food for how long the woman's going to be in labor. And then in Thunder Bay, that support person is asked to leave after 6 hours from the birth of the babe. And only one support person, they can't trade off with someone else. People in the chat are asking about a doula. So unless you only have the doula and don't have your partner, you're only allowed your one person. So what are you guys doing?
So we are, we do have one labor support person. They're able to stay through labor as well as postpartum. Where there is no, you can't switch out your support person throughout that time. Somewhat softly recommended that they didn't leave labor and delivery. We certainly didn't want them leaving the hospital back and forth, letting dogs out or smoking or, you know, that kind of thing. But now, and so they were bringing, I had one patient bring a large suitcase and it was full of food. But now the partner can go down to Tim Hortons. They can basically stay for the whole recovery postpartum period. There was some argument or some, I guess that's not the right word either, discussion required if a support person was not able to stay, especially cesarean section, when they can't get out of bed quite yet. And so that's where the kind of the push came to keep that labor support person. We don't have doula. A doula would replace a support person. The midwife, if it's a transfer of care and there's a midwife support, that the midwife, but no other family members other than their labor support person. And so most recently, like yesterday, one of my recent transfers of care actually wanted to swap out her midwife for her mother, and it's can't happen. Or even another support person or her mother for the doula. I was like, you also have a doula, and it's like, but so that went to patient relations, I'm told. Come back to me yet.
Yeah, so we consider doulas, and we always have at our hospital, professional support people. So they always counted as one of your two support people, and now they could be your one support person, but they're a professional support person. They're not truly a healthcare worker. They are not at all equivalent to a midwife. And Jennifer was alluding as yes, our midwives and some of our family physicians, right, they would still maintain a supportive care role in transfers to obstetrics, and they're still very much welcome to be part of the labor and the birth as that extra person. But they have one support person.
One more question. Dr. Kilbertus, shall we what are we advising pregnant healthcare workers, particularly in long-term care or PSWs?
Well, say that's when I sneak out the British recommendations if the patient wants to try and advocate for her to be moved in an area where she's not working within 2 meters of people, right? In her third trimester, after 28 weeks, as Jennifer pointed out, we have evidence that shows the severe morbidity certainly seems to happen in the third trimester. So infections after 28 weeks. There are case reports we didn't post about stillbirths at 15 weeks and whatnot, right? That it usually ends up just being a conversation with the patient and what can we help advocate for her to get her out of what she'd consider an unsafe environment. But
So I'll have to wrap this up, girls, and hand back to Dr. Gertson. The only last thing I was going to tell you guys what Dr. Juma had up here in the north organized, and maybe you guys are already doing that in Sudbury, but she ended up finding all the communities and batching them and assigning them to an obstetrician. And half of our practice is probably people from outlying communities. So now we're assigned to a region and we do all of it telehealth or on the phone for that region. So I'm at a Koken, Scriber in Terrace Bay or whatever, and it's kind of helping not bring patients to Thunder Bay as often. So I don't know how much, how long this will go for, or if this is going to be our new norm, but that's one thing we've done to really reduce travel to Thunder Bay.
The low-risk providers that I work with on the island, Dr. Bars and Dr. Quackenbush, we probably text about once a week. They take care of the patients that we have shared care with on the island, including Wiki. So that certainly, and then I do a lot of virtual care with those patients as well. They often have to for their induction or
awesome.
what. So risk try to.
Yeah, awesome.
Because the reserve is closed, you can't get out unless you have a.
For sure. Okay, Dr. Gertson.
Great, thanks so much, Doctors Jocko, Splinter, and Dudar. I mean, we had a truly pan-northern rounds today where we were sharing experiences in Northeastern and Northwestern Ontario. PPE is a huge issue. Was an issue at the start of COVID pandemic. It's an issue now, will be an issue in the future. So please join us next week when we will be looking at PPE and looking at a lot of the issues very specific to Northern Ontario. For our attendees, please complete an evaluation, provide some feedback to our presenters, and the evaluation link is on the Rounds website. And by leaving your name and email, we will also issue